Okay, let's go now for intracranial infection of the brain, the signs that we should not miss. Again, I have no potential conflict of interest to report. In young children, infections of the central nervous system may be contracted in fetal life or postnatally. And when we are talking about fetal infection, we should think that the brain is a developing organ. And again, what matters more is age the infection took place. If the infection is contracted very early, between the first and the second trimester, this results in malformations of the brain. If the infection is contracted later, during the second to the third trimester, this results in clastic lesions and dystrophic calcifications. Here you see 5 different patients. This is a T1 axial scan, and this is a full-term baby. It is about 8 months old, and you see that the brain is not normal. There is lack of operculization of the sylvian fissure, and here the cortex looks thick. So there is a problem of neuronal migration. Here, another baby with hydrocephalus, and this baby contracted infection in fetal life. Here is a mineralizing vasculopathy, and the baby contracted CMV infection. And here a CT scan with periventricular calcifications here and there. This is not a calcification, this is a valve. The baby was suffering from hydrocephalus, and the valve was positioned to drain the hydrocephalus. And this is another baby with, this is a T1 weighted scan, and you see that the cortex is hyperintense, and this hyperintensity is due to calcification. Again, the paradoxically high signal intensity of calcifications. So I gave you a taste of what is going to be my lecture now, and all these cases are congenital infections of the central nervous system. So now let's start with fetal infections. If you do imaging to a neonate and you see calcifications and ventricular dilatation, either with ultrasound or CT scan or MRI, please think about fetal infection. This is the first important message. What about the agents, the infecting agents? You should remember the acronym TORCH, where TO stands for toxoplasmosis, R for rubella, C for cytomegalovirus, and H for herpes. And to this acronym, you should add HIV. HIV virus may be contracted in fetal life too. What about the roots? Hematogenous, transplacental, and usually the infecting agents are toxo and viruses. Ascending transcervical, and the infecting agent are bacteria, and at birth, of course, and this is usually herpes. So if you do fetal ultrasound, what are the findings that are converging to the presence of infection? Growth restriction, abnormal amniotic fluid volume, calcification at the liver or intracranially, ventricular dilatation, ascites, hydrops fetalis, pericardial or pleural effusion, and hyperechogenic bowel. So a bunch of findings that are very important to suspect fetal infection. Let's start with the CMV. there are several explanations why we see so many anomalies after CMV infection. The one is that there is infection of the blood-brain barrier endothelial cells. The second is that there is infiltration by the virus of the monocytes. And please pay attention to this notion is that in early postnatal life, monocytes populate the brain and become microglial cells later on. So if these are infected, this is bad news. What happens with the CMV? The CMV loves the germinal matrix. There is a love story between the CMV and the germinal matrix, which is the motherland which is producing the neurons and the cortex. So what is the end result? We've seen that in congenital malformation. There is disordered migration. There is a problem with migration. And this results to lissencephaly or polymicrogyria. Generally speaking, to abnormalities of neuronal migration. The other point is that it loves the vascular wall, and this results to ischemic injury, and ischemia may lead to parenchyma necrosis and cystic encephalomalacia, and where there is necrosis, there are dystrophic calcifications. So we can see several findings due to CMV infection. And here, a child, the mother contracted early in pregnancy CMV infection, and you see the result, lack of percolization of the sylvian fissure and abnormal gyration pattern. And if you pay attention on these T1 weighted images, you will see this bright linear structure here and there and there, and these are calcifications. And they are bright due to this presence on a on a matrix with high content of hydrogen, so these calcifications affect the T1 relaxation time of this matrix. Let's go for rubella now. Rubella interferes with cellular multiplication. So children, fetuses contracting rubella present with a low quantity of neurons and glial cells, and there is hypomyelination, and for these reasons, small quantity of cells, hypomyelination, there is microcephaly. The brain is growing by multiplication of cells, but also by dressing the white matter with myelin. So the brain is small due to these two things. There may be cortical calcifications and basal ganglia calcifications. And here, this is an old exam, but you should believe me that this is a bright thing which is calcification. And please remember, I will tell you a secret now, that calcifications in the brain do not give SADU. So if you see a bright thing on ultrasound of the brain into the brain, you should think about calcifications. And you don't need to see the SADU after posteriorly to this bright spot in order to say this is a calcification. The other findings we see in rubella is cataract, glaucoma, and microphthalmia. And also the patient may have deafness. You may see congenital abnormalities of the heart, of other organs, and in that case there was pulmonary artery stenosis and a large patent ductus arteriosus. Toxoplasmosis, oftentimes you see calcifications and porencephaly. Porencephaly is a clastic lesion, a cyst into the brain due to distraction of the brain communicating with the ventricular system. And here you see that there is ventricular dilatation, you see the large ventricles, and you see a cyst formation communicating with the lateral ventricles. What happened to those cases? There is infection, ependymitis, which may lead to stenosis of the aqueduct of Sylvius, and for that you may have hydrocephalus or meningoencephalitis, which is also may be responsible for communicating hydrocephalus. And also you may see abnormal gyration pattern because toxo may intervene with neuronal migration. And here the case we've seen at the very beginning of this lecture, you see these calcifications around the lateral ventricles, and this is a drain, this is a valve, because the baby was suffering from hydrocephalus. Another case that was explored with MRI, and you see that there is dilatation, huge dilatation of the ventricular system. You see this hydrocephalus, there is a cyst of the septum pellucidum, and if you see there at the posterior parts of the brain, the gyration pattern is completely abnormal. There is pachygyria, and also you see on T2-weighted sequences this low signal intensity suggesting the presence of calcifications, and these calcifications appear with high signal intensity on T1 weighted images due to the paradoxical high signal intensity. Okay, in this lecture I will continue my teaching on Greek mythology, and I will talk to you about the Trojan horse. HIV virus, it's a very tough virus, very bad virus, and he is not attacking the enemy straightforward. He uses the Trojan horse. And what is the Trojan horse in that case? It doesn't harm the neurons and the white matter directly. It goes from the periphery. It infects the macrophages, the astrocytes, the microglial cells. These are the helpers to this HIV virus. And by infecting those cells, there are toxins secreted, and these toxins affects the neuronal cells. So it is an indirect way to affect the neurons. What are the results? Calcifications. You see here in the basal ganglia, hyperdense calcifications. There may be atrophy. You see, this looks like the brain of an old person, and also leukoencephalopathy. You see this high signal intensity in the white matter. This is an old child, and you should expect to have a dark myelinated white matter here, and this is not the case. So atrophy and leukoencephalopathy along with calcifications. Let's go now for the postnatal infections, and in this lecture I'm focusing mainly on fetal and postnatal, the neonatal, because most of people are not familiar with this bizarre neonatal period, which is seen mainly from pediatric radiologists. So what is the spread? Hematogenous, contiguous, because of sinusitis, mastoiditis, trauma, and through the peripheral nerves. The peripheral nerves may be the root for some viruses, for instance the HSV1. What is the most common infection of the central nervous system in children? Meningitis. And it is important to remember that we don't image meningitis. We don't need to image meningitis. This is a clinical diagnosis. We need to perform imaging only if we suspect complications. So, let's start with meningitis. What happens there? When you have meningitis, there is leptomeningeal vasculitis. This results to thrombus formation, occlusion of the vessel, and arachnoid necrosis. The infection spreads to the vessels and results to arachnoid necrosis. Or leptomeningeal vasculitis may lead to extension of inflammation through the Virchow-Robin spaces. Okay, so from there the infection can go to the cerebral vessels, because into the Virchow-Robin spaces there are vessels. So the infection spreads into the brain parenchyma, into the vessels of the brain parenchyma. And this results to thrombus formation, occlusion, and infarct into the brain parenchyma, of the brain parenchyma. Or it can go for cerebritis and abscess formation. And if the infection spreads into the subependymal vessels, so we can have vasculitis there and choroid plexus infection, and this leads to ventriculitis. So everything starts from the vessels, from the meningeal vessels, and then spreads deep inside the parenchyma, deep inside the ventricles, and you may have a bunch of complications. So this is my favorite slide that was given to me by the queen of brain ultrasound and of ultrasound at large, Corinne Veyrac. We are both fan of Corinne Veyrac. So, what happens if you use state-of-the-art ultrasound? You know that as pediatric radiologists, we use a lot ultrasound. This is the best tool to approach a child, a pathology in a child. And this applies not only to the abdomen, but also to the brain. We are going from the anterior fontanelle, the posterior fontanelle, the mastoid fontanelle, you name it. We use state-of-the-art technique and we can explode the brain perfectly well. So this is an excellent image by using high-frequency transducer from the anterior fontanelle, and you see the superficial parts of the brain, and these are the subarachnoid spaces, and these are vessels. And normally you should see the vessel without thickening of this surrounding, and this cuffing, this surrounding thing is the inflammatory material, and this means inflammation of the leptomeningeal vessels. And this is a beautiful, elegant diagnosis, not expensive at all. Of course, if you don't do state-of-the-art technique and you don't use this high-frequency transducer, and if you are not Corinne Veyrac, you may see this. But again, the diagnosis is here. You see a thickening of the subarachnoid spaces, and this is not normal. Again, a thickening of the subarachnoid spaces. Of course, these thickened subarachnoid spaces, which are highly echogenic, may suggest two things, either infection or hemorrhage. And of course, you should base your finding to the clinical story of the child, to the clinical picture of the patient, to the clinical information, and decide if this is blood or infectious material. So if you use MRI, which looks more easy to many people because it is not operator dependent, and you use the different sequences, and you use T1 weighted sequence with intravenous injection of contrast material, and you suspect meningitis, you will see nothing in many cases. And if you use FLAIR imaging, this is more sensitive. You will see this high signal intensity in some areas of the subarachnoid spaces here and there, and this is highly suspicious of the presence of a material into the clear CSF. This material might be either infectious material and you are going for meningitis, or blood and you are going for subarachnoid hemorrhage. And again, in those cases, you should join your information to the clinical information in order to decide what is this, what is this. So, meningitis, I told you, that goes for arachnoid necrosis and subdural collection. Arachnoid necrosis result in subdural collection. And if the collection is sterile, it looks like this. This is a plain CT scan, and this is a CT scan after contrast administration. And you see that there is a subdural collection. You recognize this subdural collection from the form of the collection, and you see that there is no meningeal enhancement here. So you can talk about hygromas. Hygromas are collections with clear liquid. But if you see something like this, enhancement of the meninges, the dura mater, and the leptomeningeal enhancement, in that case, you can talk about empyema. If you have meningitis, you may have venous sinus thrombosis, because leptomeningeal vasculitis lead to thrombus formation, and these vessels, these veins are draining into the different sinuses. And here, in that case, there was extension of the inflammation, infection into the superior sagittal sinus. You see this high signal intensity due to subacute thrombus and occlusion of the sinus, and hemorrhagic infarcts due to the occlusion of the sinus. Here you see the infarcts. There is a thrombosis of the superior sagittal sinus, and there are hemorrhagic infarcts in the brain of this child. Another case, again meningitis, resulted in venous sinus thrombosis, and again the root is leptomeningeal vasculitis, thrombus formation, and extension in that case into the left transversal sinus and the straight sinus. Here you can see the high signal intensity due to thrombosis, to subacute thrombosis of the left transverse sinus. And of course, you know that thrombosis of the different sinuses result to hemorrhagic infarcts of the brain. And in all cases, you don't see hemorrhage at the very beginning, like here, the thrombosis of the sinus lead to infarct of the basal ganglia of the thalami, and you have bilateral infarcts. As I told you, we use a lot of ultrasound, and we use ultrasound, and in order to have our state-of-the-art technique, we use color Doppler. Okay? And this child was having mastoiditis, and he presented with findings of meningitis. So my first step was not to go into the MRI. I took the baby and I went to the ultrasound suite, and I did an ultrasound coupled to color Doppler, and I tried to see the different sinuses. And here you see the transverse sinus on the right side, and this is patent. There is color into the sinus, and here on the other side there is no flow at all. So my diagnosis was thrombosis of the transverse sinus on one side. And your question would be, why you did an MRI? Because it is not always easy to look with ultrasound. There is an age limit. You can see with ultrasound until the 6th month of age. Usually you see better in neonatal period, and then the acoustic windows are closed, so you cannot see into the brain. And you can see on MRI that there is thrombosis of the sinus, and of course you look for parenchymal lesion, which is a venous infarct many times in those cases. Meningitis may lead to cerebral vasculitis. Okay, leptomeningeal infection goes into the parenchyma, into the vessels of the parenchyma, and the arteries may affect it, particularly the superficial arteries, and this may lead to occlusion and the formation of a cortical infarct. Although this image is not very beautiful, The information is here. This triangular hyperechogenic lesion, which is an arterial infarct at the periphery of the brain due to meningitis. And this is a complication of meningitis. In other cases, you may have another infecting agent, and cerebral vasculitis may lead to thrombus formation and venous occlusion, and you may have these white dots all over the brain, which are infectious infarcts due to Candida albicans in a premature baby, a very young baby, and you can see the evolution of those lesions with liquefaction and multiple dark dots targets into the brain. Many times as pediatric radiologists we deal with very young children, with premature babies, and these babies are very fragile. And one of the complications of the prematurity is venous infarcts around the lateral ventricles. And here you see a typical venous infarct, intraventricular hemorrhage, which compresses the terminal vein and leads to periventricular infarcts. And these are venous infarcts. And I was doing this examination, and I was very happy to follow up this baby, and I said, okay, this is a baby with the typical complication of intraventricular hemorrhage, a venous infarct, and I was very happy with my diagnosis. And I had the clinician behind my back, because in Greece, either you have the parents behind your back when you are doing ultrasound, or the clinician. And I'm starting feeling uncomfortable, and I say, please stay away of me, and please take care of the child. And the clinician was telling me, you know, this child presented seizures, epileptic crisis, and that was not explained by the thrombosis. So I said, who are you? And he said, I'm the pediatrician. And he insisted, so I said, this is a good pediatrician. Let's go to the MRI suite. And we did an MRI. And of course, we've seen the venous infarct, but there was another area at the superficial part of the brain affecting the cortex, and this area I was not able to explore by my ultrasound this area. So there was an additional arterial infarct to this child. So sometimes if the clinician is very noisy and insists on his clinical picture, you should pay attention and not stop with one examination, go further, do an MRI, because the superficial areas of the brain, especially the parietal areas, are not very well explored with the ultrasound. So two pathologies in the same chart. Cerebral vasculitis may lead to cerebritis, and cerebritis may lead to abscess formation. And here you see this hyperechogenic area, which progresses to a low echogenicity area, well limited, and progressively you see the liquefaction of this lesion. And this is a typical appearance of evolution of cerebritis to the formation of a cerebral abscess. Here you may see the advantage of ultrasound. You see this hyperechogenic or heterogeneous area, liquefaction progressively, and the similar imaging findings on MRI. At the very beginning, the area looks solid with a peripheral liquefaction, and later on you see the solid and the liquid component due to the evolution into an abscess. And that was an abscess due to septicemia with Serratia, or whatever the cause. So here, abscess formation. What are the typical imaging findings on MRI? Here you have a T2 weighted scan. You see a mass lesion with a heterogeneous intermediate signal intensity surrounded by high signal intensity due to edema. And on T1 weighted images, you see again the lesion with a wall, and you see the edema. And after contrast administration, you see an enhancement, and you may say, okay, this looks like an abscess. But I can tell you that it could be a metastasis, which is not very often in children, but you may see metastasis, hematogenous, or a primary lesion. Do you have any clue to differentiate an abscess from a primary or from a tumor? The clue is here by using diffusion imaging. This is an ADC map, and you see that there is restricted diffusion into this mass lesion, and this applies everywhere. Every time you have an abscess, everywhere in the body, there is restricted diffusion. Okay, meningitis may lead to ventriculitis, and you have subependymal vessel vasculitis, infected choroid plexuses, and ventriculitis. And here is the disorder. You see a parasagittal scan, you see the lateral ventricle, which is dilated, you see echogenic material into the ventricle, and you see this hyperechogenicity of the wall of the lateral ventricle. And if you go on coronal scans, you see the material into the third ventricle, and also you see liquefied lesions into the parenchyma. So you have ventriculitis plus different clastic lesions into the brain parenchyma. Subependymal vasculitis, infected choroid plexuses, and ventriculitis. And here the impressive images. You see that there is edema around the ventricles. This is not unmyelinated white matter. You see this dark thickening of the wall of the lateral ventricles. You see cyst formation, liquefied areas into the brain. And if you perform T1 weighted images after contrast administration, you see this enhancement of the wall of the lateral ventricles. And this is a typical appearance of ventriculitis, because normally you don't see enhancement of the wall of the lateral ventricles, of whatever ventricle anyway. Okay, cerebritis, especially neonatal cerebritis due to herpes simplex type 2, may look like this: hyperechogenic foci here, there, all over the brain. And this is cerebritis leading to encephalomalacia. There is necrotic meningoencephalitis in those children, and this leads to loss of neurons and glial cells. So you may see this abnormal signal intensity on MRI, this hyperechogenic foci in the brain. And please be careful, if they are very bright on ultrasound, please think on hemorrhagic foci. This is cerebritis associated with hemorrhage, and this very hyperechogenic foci suggests the presence of hemorrhage, and this gives rise to encephalomalacia later on that you can beautifully depict on MRI. The typical encephalitis of herpes simplex type 1 affects the temporal lobes. Bilateral, high signal intensity, you may have hemorrhagic foci, but also it may affect other areas of the brain. Typical appearance, the same we see in adult patients. Tuberculosis. It doesn't exist only in developing countries. You may see tuberculosis also in Europe, especially with the migration we have in Europe. You may see more and more. There is hematogenous spread. There are small tuberculous granulomatous lesions which are called Ridge foci. And these foci may rupture into the subarachnoid spaces, especially in the basal cistern, and may appear like this. After contrast administration, you see enhancement and thickening of the basal subarachnoid spaces with these nodules and material into the subarachnoid spaces. And you may have lesions also in the parenchyma, enhancing lesions, and these are quite typical in the posterior fossa and also in the supratentorial areas. And also, tuberculosis may affect again the vessels, and you may have panarteritis, c'est-à-dire, friends. That means arteritis of all vessels of the brain, and this may result in infarcts. So don't be surprised to see pachymeningitis at the basal cisterns. Don't be surprised to see lesions into the parenchyma, ring-enhancing lesions, and don't be surprised to see in a patient with tuberculosis infarcts, stroke lesions. And if you perform MRI in a child with tuberculosis and you see this kind of lesions of low signal intensity on T2 weighted images, intermediate signal and peripheral enhancement after contrast administration, please think about caseating granulomas. These appear of low signal here, and this is a T2 effect even on T1 weighted images, and this is due to T2 shortening by the paramagnetic free radicals produced by the macrophages present in that lesion. Okay, so the low signal intensity on T2 is a T2 effect, but a T2 effect may be seen also if it is strong enough on T1 weighted images. We shouldn't forget the parainfectious conditions, and these are the ADEM, and ADEM is acute disseminated encephalomyelitis. It is usually monophasic. It is an autoimmune reaction against myelin, and often there is a viral infection before the development of this condition. You may see this type of lesions all over the brain, high signal intensity with a bit hazy borders. It may look like multiple sclerosis, and sometimes it is difficult to differentiate. Again a case, but this is a monophasic disorder, and you see that on follow-up the lesions decrease or sometimes, many times, disappear. Where is the clue to differentiate that kind of entity with multiple sclerosis? The clue is on the spine. You perform an imaging of the spinal cord, and you see that there is an extensive lesion extending longitudinally more than 3 vertebral bodies, and if you do axial scans, you see that this lesion occupies more than the 2/3 of the spinal cord. This is typical of ADEM, and you don't see this kind of lesions in multiple sclerosis. And if you follow up the child, you will see that there is a normalization of the appearance of the spinal cord, and you see that there is a normalization of the appearance of the brain. Here, another case of ADEM, looking pretty much like multiple sclerosis with ring enhancement, and you should image the spinal cord in order to make the difference. Tumefactive multiple sclerosis, very typical case. You see this large lesion looking like a brain tumor, multiple brain tumors in that case, but the clue is on contrast enhancement. If you inject contrast, you see this incomplete ring enhancement. At the border between the white matter and the gray matter, there is no enhancement of the lesion. And this is typical of tumefactive MS. Again, you use the spinal cord. This is the clue to differentiate with other lesions. And you see that there are lesions in the spinal cord. You see these lesions that are not very extensive. They are extending in less than 2 vertebral bodies. And if you perform axial scans, you will see that the lesion is extending in less than 2/3 of the axial, on the axial images, in contrast to ADEM. So, coming to the end, what is the take-home message? Early fetal infections lead to malformation and migrational abnormalities. So it's a bad thing to contract infection early in embryogenesis, early in fetal life. Late fetal infection, of course, there are important complications like calcifications, hydrocephalus in many times, germinal-lysis, or mineralizing vasculopathy, like in cases of CMV. CNS infection is a love story. It's a love story between the infectious agent and the brain vessels. But as all passionate loves is a killing love. And if you think infection, please think about vessels. This is the key point. You don't agree, but it is true. Think about vessels. Think about vessels in the meninges, the parenchyma, and the ventricular wall. And if you think about inflammation, you should think about perivascular spaces. Okay, if you do an ultrasound and you see these kind of things, mineralizing vasculopathy, calcifications, hydrocephalus, is this a fetal infection or a postnatal infection? Go for MRI. The answer is here. Because if you see abnormal gyration pattern and if you see calcifications all over the brain, this is an early fetal infection. This is the cause of these abnormalities. If you do ultrasound, because as I told you, we start with ultrasound, and you see this kind of findings, you see this hydrocephalus, you see this echogenic material, you see this abscess-like formation, this is a postnatal infection. And if you do MRI, you see some additional information. This looks pretty much the same, but here you have the confirmation of ventriculitis and other additional lesions in the brain. If you do MRI in a patient with a neurologic symptomatology and you see this kind of lesion, don't say multiple sclerosis. It's a long life disease. You may say ADEM. And if you are not sure that this is ADEM, go for spinal MRI. And if you see this kind of extensive lesion, think about ADEM. Give some good news to the patient. And of course, you follow up this patient and you may see that this kind of lesions disappear. But if you see this kind of lesions there, don't say brain tumor. This is an incomplete ring enhancement, and you don't see classically with a brain tumor this kind of lesions into the spinal cord. If you see this kind of lesions, think about multiple sclerosis, especially if on axial scans these lesions are posterolateral, and on sagittal scan they are not extending more than 2 vertebral bodies. So this is ADEM versus multiple sclerosis. Thank you for your attention.